Hi, my name is Anna Catherine Barker,
And I'm Roger Brickley.
and we are talking today about deep vein thrombosis, also known as DVTs. DVTs are the leading cause, a preventable cause of death in the U.S. Studies cannot pinpoint exactly where they come from. Deep veins are unidirectional, and veins have a valve that closes very fast to prevent backflow. Deep veins thrombosis usually occur in the femoral or iliac veins, but they can occur in any deep vein in the body. So studies do not know exactly what DVTs come from, but Virchow's triad tells us 3 different sections of possible causes. Endothelial damage. These are patients that have had trauma, surgery, dialysis access catheters, cardiovascular disease. These patients are all at risk for DVTs and should be closely monitored. Also, any patients that have venous stasis. These patients may have obesity, have been on bed rest, be immobilized for longer periods of time for some sort of disease or immobility reasons, or have spinal cord injuries. These patients also need to be monitored regularly and assessed for DVTs. And then the third area is altered coagulation. So because DVTs usually, they're occurring in the veins and they are blood clots that are attached to the venous walls, the coagulation is very important. So altered coagulation patients are patients with cancer, or patients that may be pregnant, patients that have protein S or C deficiency, patients that have polycythemia, or patients that have elevated clotting factors. So you can see right here that DVTs usually have blood clots that are attached to the venous walls. And the number one complication from a DVT is a pulmonary embolism. And pulmonary embolism occurs when one of those blood clots that was attached to the venous wall breaks away and is detached, and now travels back and is traveling back up towards the heart. Pulmonary embolisms and DVTs are very silent killers because it's hard to detect them early, and their signs and symptoms are not always clear. But some signs and symptoms nurses should be looking out for when monitoring their patients is edema or swelling in the extremities, especially comparing to the other extremity. They should also be feeling the extremities to see if they are warmer to the touch than they should be, or if any of the extremities have tenderness or pain, or functional impairment. These nurses need to be monitoring all those extremities, especially for patients who are more at risk for them. There is a DVT at-risk warning that nurses can document on, and if you have a score of 2 or more, then you are likely to have a DVT, and the nurse needs to watch out for that. And if you have a score of 1 or less, then you're unlikely to have a DVT. So this table right here explains what the patient gets a score for or not. If the patient has cancer, they automatically have a 1. If the patient is paralyzed or immobilized in any way, they also receive a score of a 1. If the patient has been bedridden or immobilized for 12 weeks, 3 weeks or more, they would receive a score of 1. If there is any type of localized tenderness or redness or swelling in an extremity, they receive a 1. And they also receive a 1 for if their calf is swollen compared to the other calf, if any part of the extremity is tender or in pain, or if any part of the extremity is swollen. And if they have previously had a DVT, they automatically receive a 1 as a score. So DVTs are very hard to detect, but they can be prevented, and they're something very serious because they can lead to a major complication and in which people want to prevent.
All right. As far as treatment goes, prophylactically is how we really prefer to treat them. Obviously, avoiding them altogether is the best option. So prophylactically, we're going to look at both mechanical and pharmacological options. On the mechanical side, IPCs, or your intermittent pneumatic compression, as well as your GCS or graduated compression stockings, are 2 of the primary ways that we try to help blood flow in that area and decrease the chances of a DVT. The purpose is to decrease the venous stasis and also to increase fibrinolytic activity. We've read a lot of studies, and all of those studies, regardless of where they were conducted, indicated that these devices are helpful, but there are some concerns in multiple studies regarding how we're actually using them. One of the studies indicated that nurses monitor or put on the devices to begin with, but then don't necessarily monitor what's going on with them on a continuous basis. So for example, if a patient comes in edematous and they've got very swollen legs, well, if you diurese that patient and 3 days later their legs are much smaller, then those graduated compression stockings aren't doing nearly the good that they were doing when you first put them on. So continuing to monitor that is a big issue. In addition to that, continuing to conduct thorough assessments on those patients, including your pedal pulses, the edema levels, and your skin integrity. Some studies indicated that nurses were not as thorough as they could have been regarding removing the devices and conducting a thorough assessment with the devices removed. Looking at the pharmacological side of things, heparin is going to be our primary means of trying to keep the blood flowing through that area, thinning it out a little bit, and making sure that it keeps moving. So the purpose is to prevent those fibrin deposits, and while heparin doesn't necessarily prevent or break down those clots, it will keep them from building up more than they already are. So the effectiveness of those is, again, by studies reiterated that it is a very effective measure, but the main problem with heparin is the bleeding aspect. Patients that are already prone to bleeds are going to be even worse off if they're taking heparin, and then patients that weren't necessarily prone to bleeds may be more prone just because they're on that greater heparin regimen than they necessarily need. So some of the things that we need to be looking for as nurses are the signs that those bleeds are taking place, such as bleeding in the gums, hemorrhage, blood in the urine and the stool, emesis with blood in it. All of those could be signs that there's bleeding going on internally that we don't necessarily see. So if a DVT does actually exist, the patient's probably not just going to be on heparin, but they're also going to be on some sort of thrombolytic regimen to try to break down the clots that already exist. So between those two, we definitely need to keep a close eye on all of their clotting factors, the PTT-INR, those types of things, as well as their hemoglobin and hematocrit levels. So we need to make sure we're monitoring those and keeping the doctors advised on how that regimen is going. If the heparin regimen is too aggressive and those blood clotting factors are the blood is not clotting enough, then you can give protamine sulfate to try to as an antidote for the heparin, so that'll slow that effect down. In addition to that medical regimen, as nurses we need to continue to provide comfort for those patients, because obviously in that extremity especially they're going to be in a lot of pain, there's going to be a lot of swelling that we've already talked about. So making sure that we give them the analgesics if possible to control the pain, or non-medicinal remedies such as warm compresses or anything else that might help decrease the swelling and decrease the pain in that area. So that was our presentation on DVTs. I hope you enjoyed it, and thank you for your time.
Thank you.